Hello, my name is Dr. Cranial. I'm assistant lecturer here at the University of Pretoria, and I will be reviewing a series of neuroanatomy lectures with you. Today's lecture is on the brainstem and cranial nerves. When thinking about the brainstem, it has many functions. It is a conduit for the transmission of information between the cortex and the spinal cord. We'll call those the long tracts. It is also the conduit for information between the cortex and the cerebellum. It's home of most, but not all, of the cranial nerve nuclei, cranial nerves 3 through 12. It is also home of some of the brainstem nuclei that project down to the spinal cord to control primitive involuntary movements, particularly those with balance. And lastly, it is home of the nuclei that will modulate cortical diencephalic cerebellar or brainstem activity, things like the substantia nigra, the reticular activating system, etc. When looking at the brainstem, you can see all of those different functions on this diagram. Posteriorly, we have all of the cranial nerve nuclei here, and here we have a demonstration of the reticular formation, one of those nuclei that controls other cortical diencephalic and spinal activity. The cerebellar peduncles are back here, quite dorsally transmitting information between to and from the cerebellum. And the cerebral peduncles are ventrally, which contains the long tracts transmitting information between the brain and the spinal cord, or the spinal cord and the brain. When looking vertically at the brainstem, now as you know, it can be divided into three parts: the midbrain, the pons, and the medulla. And this will help you localizing in brainstem processes. This vertical plane, in which the brainstem is being affected, is best identified by using the cranial nerves this function. You can also see the cranial nerves line up in certain columns. And we'll talk about the motor columns, which are more medially, and then it will be followed by the sensory columns, which are way out laterally. So there are three columns in each set of cranial nerve nuclei in the sensory component. The three columns are the general, the visceral, as well as the spatial sensory columns. So general or somatic sensory column refers to the information about proprioception, vibration, touch, pinprick, and temperature. And this column is only going to be filled with the spinal nucleus of the trigeminal nerve. This actually runs the entire length of the midbrain up to the medulla and actually even a little bit into the cervical spinal cord. This is the most lateral of the sensory columns. The visceral sensory column is an easy one to remember because there's actually only one nucleus in it. It's aptly named the solitary nucleus because it's the only nucleus in that column, and it really has two roles. It has the role of receiving visceral organ information from the vagus regarding the heart, the lungs, and the GI tract to about 2/3 on the way across to the transverse colon. And then it also receives information about taste sensation from the three cranial nerves that provide sensory information from the tongue, the 7th, 9th, and 10th cranial nerves. And finally, we have the special sensation column. This is kind of our core special sensation. And in this column, we really only have two sets of nuclei, all associated with a single nerve, the 8th cranial nerve, where you'll receive both cochlear information for hearing as well as vestibular information for balance. The motor cranial nerve nuclei also reside in three columns. Two of the names are the same, in other words, the general motor as opposed to the general sensory column, and then we have the visceral motor as opposed to the visceral sensory column. And the one that is different would be the brachial motor. So you will go over those individually. General motor refers to the cranial nerve nuclei that innervate skeletal muscles of the eye or the tongue. So this will be the cranial nerves 3, 4, 6, and cranial nerve 12. The visceral motor will be the parasympathetic innervation to the pupil and the lens through the 3rd cranial nerve, the lacrimal gland and the salivary glands for the 7th cranial nerve, the parotid gland through the 9th cranial nerve, and the heart, lungs, and 2/3 of the GIT tract through the 10th cranial nerve or the vagus nerve. these are all the parasympathetic cranial nerves. Cranial nerves 3, 7, 9, and 10. There is no sympathetic or visceral motor nuclei in the brainstem, as the sympathetic part originates in the posterior part of the hypothalamus. And finally, we have the brachial, which refers to the embryonic development and specifically the muscles that derive from the structures known as the pharyngeal arches, and the 4 motor nuclei that go to the embryological structures from the pharyngeal arches are the 5th, 7th, 9th, and the 10th cranial nerves. You could argue about the 11th, but the 9th, 10th, and 11th all come from the exact same nucleus, so it's very hard to parse out how many of those are actually contributing. Therefore, that's why it's called the nucleus ambiguous, for a reason. It's ambiguous as whether or not these axons and the nuclei actually live in the 9th, 10th, or the 11th nerve. As I mentioned already, you can localize in the vertical plane by which cranial nerve nuclear axons are involved, and then you can localize in the transverse plane by which long tracts are affected. By long tracts, I mean the corticospinal tract, the anterolateral system, the descending sympathetics, as well as the dorsal columns, which are carried in the medial lemniscus system when you get to the brainstem. One thing that I have to mention is when you see multiple cranial nerve deficits without long tract signs, that should usually suggest a process outside of the brainstem, usually surrounding the brainstem in the subarachnoidal space. So returning to this picture, you can identify which cranial nerve nuclei will tell you which vertical plane you're in. So starting from the caudal region, the medulla, there are 4 primary cranial nerves that reside in the medulla, and those are cranial nerves 9, 10, 11, and 12. So if you have involvement of those nuclei, the person will have problems of his tongue, have a dysarthria or dysphagia, as well as abnormalities of the palatal reflex. So when you have these symptoms, you should be thinking that you are actually in the medullary location. There is another nucleus that I skipped over when I mentioned it, and that's the spinal nucleus, which runs the whole path down to the medulla into the spinal cord. So that is in addition to the 4 main nuclei that reside in the medulla. In the pons, you also have 4 main nuclei here. You're dealing with a motor nucleus of 5, 6, 7, and 8. So facial weakness with a peripheral appearance, usually that means when you have the forehead that's involved. Also, abduction deficits with eye movements, or when you have jaw deviation and hearing loss, will all identify to the pons, or the cranial nerves as they exit the pons. And then finally, in the midbrain, there are 4 bumps on the dorsal surface of the midbrain. Those are the paired inferior colliculi and paired superior colliculi. The level of the inferior colliculi resides 1 cranial nerve, the 4th cranial nerve, and at the level of the superior colliculi resides the last cranial nerve that enters the brainstem, which is the 3rd cranial nerve. So this gives us the 4-4-4 rule of localization. Cranial nerves 9, 10, 11, and 12 should localize you to the medulla. Cranial nerves 5, 6, 7, and 8 should localize you to the pons. And cranial nerves 3 and 4 at the level of the superior and inferior colliculi respectively, which should localize you to the midbrain. So one more thing that I want to mention is that 11 of the 12 cranial nerves exit the brainstem ventrally. The one exception, which is easily testable, is the 4th cranial nerve, or the trochlear nerve, which you can see right here. And it's not exiting the ventral surface of the brainstem, but instead coming out from behind the brainstem quite dorsally. So going back to this picture, this should help you in remembering that you can get cranial nerve injuries in the brainstem from both the nuclei back here. Or you can injure the fascicles as they run ventrally to exit the brainstem on the ventral surface. For some cranial nerves, you can't distinguish a nuclear from a fascicular lesion, so you won't be able to definitely know if you're more dorsally or ventrally in the brainstem. For other cranial nerves, as I go through each individual cranial nerve, I will point these out. The nucleus and the fascicle will give you different clinical syndromes, and therefore you will know if you're more dorsally or ventrally. So if you can't use the cranial nerves to completely identify whether you are dorsally or ventrally in the brainstem, the question that you might want to ask then is, what can you use to make this distinguishment? And here you can use the long tracts. So the cortical spinal tract, which would give you a contralateral hemiparesis, is very ventral. Any involvement here tells you that you have to at least have ventral involvement. And right here in the middle, behind the cortical spinal tract is the medial lemniscus, sending information from the contralateral body for vibration and proprioception. Involvement of this usually again tells you that you are in the middle of the brainstem. And then back here, you at the level of the cerebellar peduncles. So involvement of the cerebellar peduncles is going to give you an ipsilateral ataxia. And this tells you that you are more dorsally. So in summary, you can use the cranial nerves plus long tracts to tell you if you are ventral in the brainstem. And then you can use the cranial nerves plus cerebellar fiber to tell you whether you are pretty much in the dorsal portion of the brainstem. Or you can use the cranial nerves plus proprioception, vibration, or weakness on the opposite side of the body to tell you that you are more in the ventral portion and you're probably affecting the fascicle as opposed to the nucleus. How about medial versus lateral? Well, immediately what you can see here is, again, you have these motor tracts and the medial lemniscus, and then the motor nuclei, which are situated quite dorsally. All of these are very medial in the brainstem. Whereas laterally, you have the sensory cranial nerve nuclei, the cerebellar peduncles, and here is the spinothalamic tract that brings up contralateral pain and temperature sensation, which is ascending through the brainstem. So pain and temperature involvement plus cerebellar or other cranial nerve sensory involvement will tell you that you are on the lateral aspect of the brainstem, like a lateral medullary syndrome, or otherwise known as Wallenberg syndrome, which happens when you have a stroke on the lateral aspect of the medulla. Then cortical spinal tract involvement, as well as medial lemniscus or the motor cranial nerve nuclei involvement, will mean that you are more medially in the brainstem. Okay, to summarize what I just said. So we've got this beautiful picture of all these multicolored nuclei situated in the brainstem. But you might feel a little bit overwhelmed now and feel that you will never be able to localize within the brainstem. So therefore, I'm going to make it easy, and I'm going to give you only 2 steps to remember.
Don't be suspicious. Don't be suspicious. Don't be suspicious. Don't be suspicious.
Okay, so the first step would be to localize in the vertical plane, and then the second step would be to localize in a horizontal plane. So do you remember how to localize in a vertical plane? You'll remember we will use the 4-4-4 rule of the brainstem. So in other words, cranial nerves 9, 10, 11, and 12 will exit the medulla. Cranial nerve 5, 6, 7, and 8 will exit the pons. And then we have the 4 bumps in the midbrain. At the level of the superior colliculus, we have the 3rd cranial nerve. And at the level of the inferior colliculus, we have the 4th cranial nerve. So a lesion in the medulla will give you dysphagia and tongue deficits. Those are the major symptoms a patient will present with when they have a lesion situated in the medulla. Then if you have a lesion situated in the pons, you'll present with facial deficits and horizontal diplopia. In other words, when a patient looks at you, he will describe that the images that he's looking at will separate on a horizontal plane. And then, if you've got a lesion situated in the midbrain, a person will typically complain of a vertical diplopia. In other words, the images will separate vertically when the person is looking at you or your finger. So localizing on the transverse plane is the second step in this localizing brainstem lesions. So what we're going to do here is we first have to think dorsally and then we think ventrally. So if you've got a lesion situated ventrally, you're most likely going to have corticospinal long tract findings. If you've got a lesion situated dorsally, you might have cerebellar findings, sensory input dysfunction, or trochlear nerve dysfunction. If you remember, I said the trochlear nerve is the only cranial nerve that exits dorsally. And then the second step on localizing on the transverse plane would be to localize medially to laterally. So an easy way to remember this is to think of the 4 M's. The 4 M's are the medial nuclei. So you're going to think of the motor for general motor. So that would be the corticospinal tracts. Then you have the motor cranial nerves, as well as the medial lemniscus and the medial longitudinal fasciculus. So the medial longitudinal fasciculus I will discuss in more greater detail later on in the presentation. And then we can localize laterally in the brainstem. And the easy way to remember that is by the 4 S's. So the sympathetic tracts runs quite laterally in the brainstem. So if you've got a patient with something like a Wallenberg syndrome, you might have an associated Horner's. And then you've got the spinal nucleus of the first cranial nerve or the trigeminal cranial nerve. So when you've got involvement of the spinal nucleus, you'll typically have ipsilateral cranial nerve sensory dysfunction in the V1, V2, and V3 distribution of the trigeminal nerve. And then we've got the spinocerebellar tracts also running quite laterally in the brainstem. So a lesion situated on the lateral brainstem can cause ataxia. And then we also have general sensation. Remember those spinal thalamic tracts that I mentioned a little bit earlier on? Well, when they are involved, you lose your touch, pain, and temperature sensation. So an easy way to remember, as I said, would be to look at the 4 M's, which are medially, and the 4 S's, which are laterally. And you're going to have to think dorsally, and you have to think ventrally. And remember, I said it's unlikely to be a brainstem lesion if you've got multiple cranial nerve deficits without cerebellar dysfunction and intranuclear ophthalmoplegia by dysfunction of the medial longitudinal fasciculus, which I'll explain later, as well as long tract deficits, which is associated with motor and sensory signs in the extremities in the body. So if you don't have these findings, but you've got multiple cranial nerve involvement, then you have to be outside of the brainstem, because a lesion causing multiple cranial nerve dysfunction are bound to affect the long tracts as well as the cranial nerve nuclei or fascicles. Won't just affect isolated cranial nerve nuclei on multiple levels without involving the long tracts. So with that, we have the brainstem introduction. We will move now on to the individual cranial nerves, working our way through from 3 to 12. Cranial nerve 1, the olfactory nerve, is actually an outgrowth of the telencephalon. And therefore, it is the only cranial nerve that does not relay through the thalamus or does not enter through the brainstem. Instead, it has a direct connection to the cortex. The optic cranial nerve or cranial nerve 2 is covered in a different lecture, but that nerve will synapse at the lateral geniculate nucleus of the thalamus and then relay back to the occipital cortex. The remaining cranial nerves 3 through 12 will have some function in the brainstem. So cranial nerve 3 is the oculomotor cranial nerve. So we'll kick off this cranial nerve with a case study. So what we have here is we've got a 30-year-old diabetic woman who has sudden onset of right arm and leg weakness and double vision on upgaze. On examination, she has right-sided hemiparesis and right hyperreflexia. You examine her eye movements and you note the following. This is when she's looking straight at you. This is when you ask her to look up, when you ask her to look down. And this is what happens when you shine a light into her eyes. So the first thing, if you remember, is that I said you have to localize on a vertical plane. And then the second step would be to localize on a horizontal plane. So let's first start by localizing on a vertical plane. And by our rule of 4-4-4s, if you remember, we have the 4 colliculi situated in the midbrain, and one of the hallmark symptoms that we get there would be a vertical diplopia. So if you refer back to our case study, we can see that this person had double vision on up gaze. So that automatically puts us in the midbrain. So that's our first localization step done. We've localized on a vertical plane. Now the second step would be to localize on a horizontal plane. So if you remember, we go dorsally or ventrally. That's the first step in localizing on a horizontal plane. So where would this problem put you? We've got predominant pyramidal tract dysfunctions, which is where she's got a right-sided hemiparesis and right-sided hyperreflexia. So that automatically tells you that you are situated ventrally in the brain, in the midbrain. Okay, so then the second step in localizing on the horizontal plane would be to go whether the person's got a medial or lateral lesion. So where, if you remember correctly, I asked if you look at the medial plane, we'll have the 4 M's, and if you think laterally, you're going to have the 4 S's. So what does this patient have? She's got a predominant motor deficit, that would be medially. She might have medial limniscus deficit, but it's not situated or stipulated in this case study. I also mentioned the medial longitudinal fasciculus, which is associated with an I&O, which we don't see in this case. And then you have motor dysfunction of the cranial nerves, which would put the patient in a medial plane. So to summarize, we've got a ventral medial midbrain lesion when we think about this case study. Okay, so the oculomotor nerve is a pure motor nerve. It has 2 pieces. There's a general somatic motor, and it has a visceral motor component. We can talk about each of those individually. The visceral motor nucleus is the Edinger-Westphal nucleus, and that provides the parasympathetic innervation to the ciliary ganglion, which will then send second-order parasympathetic neurons to the pupillary constrictor that will result in pupillary constriction, as well as to the ciliary body of the lens, which will accommodate the lens. The fibers from the Edinger-Westphal nucleus, as they run in this third nerve, they run on the periphery, which makes them more susceptible to constriction or compression injuries. And since the vasa vasorum on this nerve lies in the periphery, it has penetrating branches into the nerve. They are less susceptible to ischemia because they have the vasa vasorum right around them. The motor component of the oculomotor nerve comes from the oculomotor nucleus, and we'll talk about that in a second. But it will send axons out to control the 4 muscles to move the eye. The superior rectus, which primary role is to elevate the eye, and to a lesser extent to intort the eye. The inferior rectus, whose primary role is to depress the eye, and to a lesser extent extort the eye. And then we have the medial rectus, whose primary role is to adduct the eye, and finally the inferior oblique, whose primary role is to extort the eye, and the secondary role is to elevate the eye. Beyond these eye muscles, it also sends fibers to the levator palpebrae, which will raise the eyelid. Then as the third nerve exits the skull through the superior orbital fissure, it divides into the superior branch, which goes to the levator palpebrae muscle, as well as the superior rectus, which elevates the eye. And then the inferior division innervates the remainder of the muscles of the eye, and that also gives us the parasympathetic branch that innervates the pupillary constrictor. The third nerve motor nucleus, not the Edinger-Westphal nucleus, which governs parasympathetic supply, actually is composed of 5 subnuclei. It has a central caudal nucleus that crosses the midline and will provide axons in both directions. The role of this nucleus is to send axons to the levator palpebrae muscle. Similarly, it has a dorsal median nucleus, which supplies axons to the superior rectus, and these fibers actually cross and run through the opposite superior rectus nucleus before joining the rest of the third cranial nerve, typically over here on the contralateral side. Initially, the remainder of the nuclei, which go to the inferior rectus, the inferior oblique, and the medial rectus muscles, all send out ipsilateral axons. This is important because it tells you that there's a difference between a nuclear and a peripheral or fascicular third nerve lesion. In a peripheral third nerve lesion, you'll get an ipsilateral down and out eye. The out due to the absence of the medial rectus adduction function, the down portion due to a loss of the superior rectus and inferior oblique muscle, the two muscles that elevate the eye, and you'll have an ipsilateral ptosis. You may or may not have pupillary involvement, depending on the etiology of the peripheral third nerve palsy. And it's more likely to be compressive, where you would have a non-reactive or minimally reactive pupil. If instead it was vascular, you may spare the pupil and just have a down and out eye. In contrast, a nuclear lesion will cause bilateral ptosis, since there's a single central caudal nucleus. It will cause bilateral elevation deficits because this will injure both the dorsal medial nuclei and the axons from the other side as it crosses over through each other. And then it will also injure the ipsilateral inferior rectus, inferior oblique, and medial rectus muscles. So, you know that you're in the dorsal midbrain when you have bilateral ptosis, bilateral upgaze paresis, and an ipsilateral adduction deficit, plus ipsilateral extorsion deficits. So let's look at the actual patient here. In this slide, the patient is asked to look straight ahead. And what do you see? I think the most striking piece that we can see is that there is a profound ptosis in this person. The eyelid comes down over the pupil compared to the opposite side. So we can see that there's definitely a ptosis. You might want to start to wonder whether there's a difference between the pupillary sizes. But this is quite subtle, and you might want to look at this in more detail when we have a look at the patient later on. In this slide, the patient is asked to look upwards. The most striking feature here is that there's an elevation deficit problem on the left eye. We can see that the inferior oblique as well as the superior rectus muscle is unable to elevate the left eye. On this slide, the patient is asked to look down, and as you can see, there's a depression problem on the left side as well. So this would be obviously mediated by the inferior rectus, which is supplied by the third cranial nerve. But there are subtle depression because remember, the superior oblique has got a secondary function, and that secondary function would be to depress the eye. Its primary function would be to intort the eye, but that's supplied by the trochlear nerve. So here we can see that there's a subtle depression problem in this eye as well. You can now definitely also see that the pupil on the left side is definitely bigger compared to the right side. So there's definitely an anisocora or difference in sizes and pupils when looking at comparing the two sides with each other, where the left side is larger than the right. And now there's a light being shined into this pupil. And as we can see, this one is constricting, but there's no pupillary constriction on the consensual light reflex on the opposite side. So you have parasympathetic problem with this eye plus a motility problem. This is classical for a peripheral third nerve palsy where you have a larger pupil, or in other words a mydriatic pupil that is down and out. We know it's not a third nerve nuclear palsy because this eye could elevate, and this one does not have ptosis. Because remember, a third nerve nuclear palsy, you have bilateral ptosis in both eyes. So we're moving now from the third cranial nerve to the fourth cranial nerve. The trochlear nerve, which I already told you, is the nerve that exits the brainstem dorsally at the level of the nucleus. The axons cross at the level of the dorsal medullary velum, so that the left fourth nerve nucleus provides axons to the right fourth nerve, and vice versa. The fourth nerve then will run the longest intracranial course, making it susceptible to small traumatic injuries. It will then enter the cavernous sinus and exit the skull through the superior orbital fissure. It will innervate one muscle of the eye, the superior oblique muscle. The superior oblique muscle's primary role is to intort the eye. Its secondary role is to depress the eye. So the actions of the superior oblique muscle can be remembered by using the mnemonic SOLID. So it primarily innervates the superior oblique muscle. It causes lateral rotation of the eye, as well as intorsion and depression. So this will hopefully make it easier to remember that the superior oblique muscle causes depression as well as intorsion. So before I show you what a fourth nerve palsy would look like, I figured I would go briefly some nomenclature. So there are three types of ocular misalignment. When you have the eyes looking towards each other, or one eye looking towards the nose, while the other eye is looking straight, we call that an esotropia. When one eye deviates away from each other, or one away from the nose while the other is looking straight, we call that an exotropia. And when the one eye is vertically misaligned compared to the other eye, we call it a hypertropia. And by nomenclature, the higher eye is always what's named. So in this case, this is a right hypertropia. There's no such thing as a hypotropia. So if the reverse was true, you would call this a left hypertropia. You also don't have a left or right iso or exotropias, because those are comparative from one eye to the other. So here we have a patient with a lot of pictures, and you could easily get overwhelmed by seeing all of these pictures. But let's start in the middle. When the patient is being asked to look in primary gaze, and when they're looking in primary gaze, what you can see here is that there's a vertical misalignment between the two eyes. The right side is elevated and the left side is depressed. And you could ask yourself, okay, we'll call the right side a right hypertropia. And this is because the eye is not depressed enough, or this can be because this eye is not elevated enough. So then you would have to have the patient look in a series of directions and try to answer this particular question. When this patient is asked to look to the left, away from the side of the right hypertropia, what you can see is that the hypertropia gets worse. And when they're asked to look towards the side of the right hypertropia, the vertical misalignment looks better. The reason for this is that when the eye is adducted, looking to the left, the primary depressor of the right eye is the superior oblique muscle. So if the superior oblique muscle is non-functional, you'll get a right hypertropia, worse in contralateral gaze. When the eye is abducted, looking like here looking on the right, the primary depressor of the eye is the inferior rectus. Since the fourth nerve doesn't affect the inferior rectus muscle, the hypertropia will relatively correct and it will look better. So right hypertropia, worse on left gaze, is consistent with a fourth nerve palsy on the right. Now this could localize either to the right peripheral nerve lesion or much less commonly a left trochlear nucleus lesion. There are also manipulations that you can do with head tilt, and that will make the hypertropia better or worse. But I will save that discussion later on when I'm talking about head tilt in terms of vestibular function, when I discuss the vestibulocochlear cranial nerve. Okay, so let's look at the other midbrain syndromes that we get. So don't be alarmed. This can or seem overwhelming, but if you apply those principles that I mentioned, we can easily simplify this process. So let's localize vertically by the rule of 444. So if you look at 444, midbrain lesions will have a vertical diplopia. So all of these syndromes should have a vertical diplopia. So we can see here all of them affect the third nerve, causing that vertical diplopia. Then the second step would be to localize on a horizontal plane. Remember to start dorsally and then move ventrally. So let's look at these. So let's start off with a ventral midbrain syndrome. So what else do we have ventrally? We have the pyramids. Therefore, we're going to automatically have a vertical diplopia from a third nerve palsy. And then we're going to have a contralateral hemiparesis on the opposite arm and leg because of that ventral portion of the midbrain that's affected. Now, secondly, let's look at a lesion that affects the whole transverse plane on the one side of the midbrain. And this is referred to as Benedict syndrome. So let's again start dorsally and move ventrally and then from lateral to medial. So let's see what's going to happen here. So remember, this is automatically in the midbrain. So therefore, we're going to have an automatic third nerve palsy. So as we look at this picture, we've got dorsal involvement as well as ventral involvement. So if you think about what happens dorsally, we've got cerebellar fibers that comes in here. So therefore, the person will have ataxia. So therefore, they're going to have, so you can see here, we've got automatic ataxia. And then we've got, because it affects the whole transverse plane, we also have ventral involvement. And therefore, when we've got ventral involvement, we're going to have hemiparesis. And this is termed as Benedict syndrome. And then lastly, we can affect the dorsal aspect of the midbrain. And remember, again, if you localize vertically, we're going to have that third nerve palsy because we're in the midbrain, therefore a vertical diplopia. Now, because we are situated dorsally, we're going to have a contralateral ataxia on the opposite side, and that's referred to as cloud syndrome. Okay, now I'm going to look at another case study that will introduce the next topic that we're going to look at for the brainstem. So this is going to kick off with a video. As we can see, the patient is being asked to look to the right. You can try to pay special attention to subtle abnormalities that you note in her face. So the pen is now going to cross over the midline. You can see she's got normal depression of both eyes. Normal elevation. Look at while she's talking. You can see there's a decrease in the nasal labial fold on the left side. And now look at the eye. This one is not abducting at all, but this one is adducting. So she's got an isolated abduction deficit on the left eye. And as you can see here, while she was talking, there's also no movement on the left side of her face. Now she's been asked to make facial expressions. She's being asked to close her eyes. And now we're testing the orbicularis oculi muscle. Look at that, the left is substantially weaker than the right. She's asked to elevate her frontalis muscle or to activate the frontalis muscle. And as you can see, this left side is not working at all. So it seems that she's got a hemifacial involvement. And here she's been asked to give action against resistance, and you can see that the right arm is really weaker than compared to the left arm. And the same happens for the right leg. We can see that the right leg is weaker than the left leg. At this point in time, the most likely area of localization is either in the right dorsal pons, the left dorsal pons, the right ventral pons, the left ventral pons, or in the suprachoroidal space. So as you can see here, it's most likely going to localize to an aspect in the pons if you look at these answers. Okay, so let's think about localizing in the brainstem. Remember, there were two steps. We first have to localize on a vertical plane, and then we have to localize on a horizontal or transverse plane. So let's start localizing on the vertical plane. So when you think about the rule of 4-4-4s, this most likely is going to localize to the pons, because this patient had a lot of facial deficits. She had a left-sided hemifacial weakness, and then she also undoubtedly had horizontal diplopia because that left eye was unable to abduct. So that places us very nicely in the pons. Okay, now the second step would be to localize on a transverse plane. So looking at the pons in the transverse plane, we first have to localize dorsally and then ventrally. So what were the two structures that we have that profoundly sits ventrally and dorsally? It would be the corticospinal tracts causing motor weakness. And when we move dorsally, we can see that we typically have cerebellar, sensory, and trochlear nerve deficits. So for this case study, it automatically puts us quite ventrally at the level of the corticospinal tracts in the pons, because this patient had weakness in the right arm and the right leg. Now remember, going back to the transverse plane, we now have to go to the second step in localizing the transverse plane, and that would be to go from medial to lateral. All right, so let's think, is this patient's lesion sitting medially or laterally? And when we think about the case study, we can see that the patient had profound motor weakness for general motor. The corticospinal tracts were involved, the arm and the leg. And again, the patient had motor cranial nerve deficits as they were transversing out quite ventrally. So we've got a patient that's most likely localizing to the ventral pons. So going back to our case study or questions that we have. All right, we'll skip the cranial nerve 5 for a second, and we'll discuss the abducens nerve so that we can finish the discussion of eye movements until we get to the vestibular section. So the 6th cranial nerve by the 4-4-4 rule is going to be the first nerve that we'll deal with outside of the midbrain. The oculomotor and the trochlear were in the midbrain at the levels of the superior and inferior colliculus respectively. So we'll look down here in the pons. It's going to come out quite ventrally because every cranial nerve comes out ventrally except for the trochlear nerve. And so here's the abducens nerve that we can see here on the slide. So the abducens nerve is a pure motor nerve. It's a pure motor general somatic nerve, just like the 4th nerve. And just like the 4th nerve, it innervates only one muscle for eye movement, and that is the lateral rectus muscle. The 6th nerve leaves the pons, actually takes quite a circuitous route in which it rises up over the temporal bone before taking a 90-degree turn into Dorello's canal. And then it enters the cavernous sinus to leave the skull through the superior orbital fissure where it reaches the eye, the lateral rectus muscle of the eye. And because of this 90-degree turn across the temporal bone, it is susceptible to compression by elevated intracranial pressure, causing a false localizing sign. A peripheral 6th nerve lesion causes an ipsilateral lateral rectus deficit, or in other words, an abduction deficit of the eye. So here's a map of this whole eye movement system. So here is the eye where eye movements originate, which are in the frontal eye fields here on the right. And they will then send axons, which will descend through to the anterior limb of the internal capsule. It will then enter the cerebral peduncles and come across down here to the pons, where they will cross and synapse here at the paramedian pontine reticular formation, abbreviated as the PPRF. It will then send a brief interneuron to the left abducens nucleus. And this abducens nucleus has two sets of neurons in it. In the first set, the neurons that will make up the ipsilateral cranial nerve, and the second set, where axons will be sent to the contralateral medial longitudinal fasciculus that will send to the right oculomotor nucleus. So it will activate both of these sets of neurons. It will therefore send a signal out to the abducens nerve to move the left eye to the left, abducting the eye. It will then send a signal via the right medial longitudinal fasciculus to the subnucleus that controls the medial rectus in the oculomotor nucleus complex. It will then move the right eye to the left. Therefore, adducting occurs via this medial rectus of the right eye. So the normal frontal eye field on the right comes down and causes movement of the left eye to the left and movement of the right eye to the left as well. So this creates conjugated gaze. If you have a lesion of the sixth nerve peripherally, which we can see here, or in the fascicle, you would have an intact ability to move the right eye to the left, but you would lose the ability to move the left eye to the left. Or in other words, you will have an ipsilateral abduction deficit of the left eye. So if instead you put a lesion here at the nucleus instead of the nerve, it will create a nuclear lesion. This is the second example of a nuclear lesion. Remember that first being the third nerve nucleus, in which a nuclear lesion could be differentiated from a fascicular or peripheral third by creating bilateral ptosis, bilateral upgaze paresis, and an adduction deficit of the one eye. So if you put a lesion here at the abducens nucleus, you will damage both axons that will go out via the sixth nerve, as well as the axons that will cross over the medial longitudinal fasciculus, going to the right oculomotor nucleus complex. And as a result, you will have neither left eye movement of the left eye nor left eye movement of the right eye. So here you get a gaze palsy as opposed to an abduction palsy. And lastly, if you put a lesion here in the medial longitudinal fasciculus, you would have the ability to still abduct the left eye, but you would not be able to bring the right eye to the left side. You would have an adduction deficit of the right eye, only with conjugated gaze movement to the left. And this is referred to as an intranuclear ophthalmoplegia, or an INO. So just to highlight an important piece of information, this medial longitudinal fasciculus does not control convergence. So a patient with an intranuclear ophthalmoplegia from an MLF lesion will still be able to adduct or converge both of their eyes when looking at a neurostimulus, because the center of convergence actually sits in the midbrain. So you might feel a little overwhelmed right now. Therefore, I'll go through this principle a couple of more times. Here's an example of a patient that is being asked to look to the left. And you can see that both eyes have moved conjugatedly to the left. So this signal started in the right frontal eye field. It then made its way down to a healthy left paramedian pontine reticular formation, which then made its way to a left healthy sixth nerve nucleus, and then made its way across via the left sixth nerve, causing abduction of the left eye. And then also subsequently crossed over via the medial longitudinal fasciculus to the right medial rectus subnucleus, which then innervated a healthy right medial rectus, causing the right eye to move to the left. In contrast here, the patient is being asked to look to the right. So that signal that started here in the left frontal eye field made its way down to a right paramedian pontine reticular formation, which then sent out fibers to a healthy right sixth nerve nucleus complex. It then made its way through a healthy medial longitudinal fasciculus to the left side, causing adduction of the left eye. But it did not make its way out through a healthy right-sided peripheral nerve 6 or a 6 fascicle. So therefore, an abduction deficit occurred here on the right. Remember, if the lesion affected the 6th nerve nucleus or the PPRF, you will damage both axons that will go out to the 6th nerve as well as the axons that cross over via the middle longitudinal fasciculus that would cause a gaze palsy to the right because both eyes would not be able to move to the right, where both eyes would only move to the left, which we saw here, because in other words, he was able to look to the left because the opposite system was still working very nicely. So here a patient is being asked to look at this finger here on the right, and as you can see, there's normal abduction of the right eye with a loss of normal adduction of the left eye. So this would be referred to as an internuclear ophthalmoplegia. And this localizes to the left medial longitudinal fasciculus. So let's go over the system again. If we start from the beginning here, we have a normal left frontal eye field, which shoots down fibers to a normal right paramedian pontine reticular formation or PPRF here on the right, which is the normal, as well as a normal 6th nerve nucleus and normal right peripheral 6th nerve, causing abduction of the right eye. But there's now a abnormal left medial longitudinal fasciculus, causing information that is being sent to this 3rd nerve to cause adduction to be lost. And then therefore we get this adduction failure on the side of the MLF lesion. Alright, let's review this topic one more time. So in this case, we're asking this patient to look to the right. So you can see there's normal conjugated eye movements to the right. So let's quickly see what happens. So we've got the left frontal eye fields that are still intact. And this is going to shoot fibers via the anterior limb of the internal capsule as well as the cerebral peduncles to the right PPRF 6th nerve nucleus complex. It's then going to communicate via the 6th nerve nucleus to the right 6th nerve, causing the right eye to abduct. And then it's going to shoot fibers via the middle longitudinal fasciculus to the left 3rd nerve oculomotor nucleus complex. That's going to shoot out fibers to the left eye, causing the left eye's medial rectus to be activated and then causing the left eye to adduct. So therefore both eyes are moving to the right. So what's going to happen now is if we've got an MLF lesion here on the right, the right eye is going to have failure of adduction, but the left eye will still be able to abduct. So let's look quickly at a case here. So this is the same patient, but then we ask him to look to the left. And as you can see, while he's looking to the left eye is abducting, but the right eye is having adduction failure. So let's look at what happened here. So here we've got the right frontal eye fields. And these frontal eye fields are then going to shoot out fibers that goes via the anterior limb of the internal capsule, the cerebral peduncles, to the left-sided cranial nerve 6 PPRF nerve complex. It's then going to shoot out fibers via the peripheral 6th nerve to the left side's lateral rectus, causing the left eye to abduct. But now, because there's a lesion here situated in the MLF, this 6th nerve fails to communicate to the right 3rd oculomotor nucleus complex, therefore causing adduction failure of the right eye. Alright, since we skipped the 5th cranial nerve, we will now return to it. So again, we are on the points by the 4-4-4 rule, with the exception that I mentioned earlier, that the spinal nucleus of 5 will actually run down into the medulla and into the cervical spine. The trigeminal nerve, or the fifth cranial nerve, is the first nerve that has both a mixture of sensory and motor components to it. It's primarily a sensory nerve, but it does have other features as well. And we'll start with this portion people think about regularly, and that's the sensation to the face. And so there are three divisions of the sensory branches of the trigeminal nerve. The trigeminal nerve, if you go back to the columns of the brainstem, have a general sensory column which contains both the spinal nucleus of 5 as well as the main sensory nucleus of 5. We'll talk about what each of these nuclei do in a second. So there are three branches of the trigeminal nerve. This is the ophthalmic branch, which will supply the forehead, a little bit of the top of the skull, as well as above the eyelids, and the upper eyelids as well as the bridge of the nose. Then there is the maxillary division, which will do the lateral forehead, as well as the inferior eyelids, and the lateral nose and the upper part of the lip. And then finally, there's the mandibular division, which will do the angle of the mandible, as well as the lower lip and part of the chin. The ophthalmic division runs through the cavernous sinus and exits the skull through the superior orbital fissure. It is the afferent portion of the corneal reflex. The maxillary division runs through the cavernous sinus, but it exits the skull through the foramen rotundum. The mandibular division does not run through the cavernous sinus, and that can be clinically useful and often tested component when describing different clinical syndromes. It exits the skull through the foramen ovale, and the mandibular division is the division that also contains the brachial motor fibers. And so, what are those brachial motor fibers do? They go out and innervate the four muscles of mastication: the masseter, the temporalis, the medial and the lateral pterygoids. They also innervate the two tensors, the tensor villi palatini and the tensor tympani muscles, as well as the two strap muscles, which are the anterior belly of the digastric and the mylohyoid muscles. So this is a useful mnemonic to remember the motor muscles that are innervated by the trigeminal nerve. And this is called my tensors dic ans for mum, abbreviated as mylohyoid, tensor villi palatini and the tensor tympani muscles, as well as the anterior digastric muscle, and then also the muscles of mastication, which are the temporalis, the masseters, as well as the pterygoid muscles. The tensors and strap muscles, when they are dysfunctional, is hard to identify on clinical symptomatology, but you can identify clinical symptomatology when there is a disorder of the muscles of mastication, particularly the lateral pterygoids. The lateral pterygoids kind of pulls the jaw forward to allow it to open with gravity. And when you therefore have a lesion, you have trouble opening your jaw on that side when the normal side opens. That causes a deviation of the jaw towards the affected side. So the sensory fibers of the trigeminal nerve can run through and synapse on two general sensory nuclei. As I've mentioned them already, the main nucleus of 5, as well as the spinal nucleus of 5. Each nucleus is going to receive axons from all three divisions: the ophthalmic division, the maxillary division, as well as the mandibular division. The main sensory nucleus of 5 controls vibration, proprioception of the face. These axons are going to come in and synapse on this nucleus. And most of them are going to cross and ascend in the trigeminal lemniscus, which runs right near this medial lemniscus here. They will end up synapsing on the ventral posterior medial part of the thalamus before projecting to the cortex. A few axons will actually not cross and run ipsilaterally, which will provide some redundancy in this information, and therefore it makes it harder to develop ipsilateral sensory loss above the level of the main nucleus in the pons. The fibers that are conveying pain and temperature sensation will bypass this main sensory nucleus and instead descend into the spinal tract of the trigeminal nucleus, where they will then synapse on the spinal nucleus of 5. which kind of runs in the caudal pons, the entire medulla, and even down into the cervical cord. Fibers from the center of the face with the shortest descent and fibers from the most lateral portion of the face will actually descend the furthest. They will then synapse on this nucleus, cross over, and run up next to the anterolateral system, in which it is known as the trigeminal thalamic tract. This is very localizing, this pinprick and temperature sensation, because above the level of the main sensory nucleus of 5, you will have body pinprick, temperature, vibration, proprioception, and face pinprick, temperature, proprioception, vibration, all running together. So any lesion above the medulla, in the pons, or in the midbrain will result in a contralateral face, arm, and leg sensory loss. In contrast, if you're down here in the caudal pons or the medulla, you won't have any loss of vibration and proprioception from the face, and you will interfere with only the descending axons that control ipsilateral pinprick temperature sensation of the face, which are running very close to the fibers coming in from the anterolateral system from the contralateral part of the body that are ascending to the VPL part of the thalamus. Therefore, a lesion here will cause crossed checkerboard sensory symptoms, in which ipsilateral loss of pain and temperature sensation occurs in the face, as well as contralateral loss of body pain and temperature sensation occurs, coming in from the spinothalamic tracts. And therefore it's very localizing, and the only place where you will be able to see this is really in the caudal pons or in the medulla. Alright, now we'll move on to the facial nerve. We're still in the pons based on the 4-4-4 rule, and the facial nerve is the first of the more complicated nerves. It's going to have multiple motor components. So these are the brachial motor fibers of the facial nerve. These fibers are going to run out and innervate all the muscles of facial expression. They're also going to innervate the stapedius muscle in the inner ear. They're going to innervate the strap muscles, the posterior belly of the digastric, and the stylohyoid muscles. Again, most of the strap muscles clinically don't have much of relevance. The stapedius involvement can give patients hyperacusis with a facial nerve lesion, but classically we think of facial weakness as the primary manifestation of facial nerve brachial motor lesions. The brachial nuclei of the face are a little bit more ventrally displaced compared to the other motor nuclei. So this is where the facial brachial motor nucleus sits. And as you can see, it takes a little bit more of a circuitous route within the pons. So instead of just exiting ventrolaterally, the fascicle actually runs dorsally and medially. It wraps over the 6th nerve nucleus, causing a bump on the floor of the 4th ventricle, which is known as the facial colliculus, before the axons then turn out laterally and leave ventrolaterally. A lesion in this facial colliculus creates a clinical syndrome, the facial colliculus syndrome, in which you'll get a peripheral or fascicular 7th nerve. So this syndrome will involve both the forehead as well as the lower part of the face. And then you'll also get a gaze palsy on the same side. Remember the gaze center for the cranial nerve 6 causing a gaze palsy? So to summarize, a lesion sitting in the facial colliculus, ipsilaterally, you will get what looks like a lower motor facial 7 weakness and an ipsilateral gaze palsy, which localizes perfectly to the facial colliculus. In addition to this brachial facial motor nucleus, there is also a visceral motor nucleus known as the superior salivatory nucleus. It's going to make up half of the small axons that runs with the facial nerve, known as the nervus intermediatus of Rysberg. The other half is made up of the chordon tympani. So the chorda tympani provides taste sensation to the anterior 2/3 of the tongue and will synapse with this solitary nucleus here, of which we'll talking about in a couple of minutes. So this superior salivatory nucleus and the facial nerve exit the skull through the internal auditory canal, and then they quickly exit that and enter the facial canal. Early in the facial canal, the nervous intermediates will bifurcate into the greater petrosal nerve, of which which will exit the facial canal and run to the orbit to innervate the lacrimal glands, of which is in charge of tearing. The facial nerve will also continue as the chorda tympani. The chorda tympani at that point in time conveys both taste fibers as well as visceral motor axons destiny to the sublingual glands, as well as the submandibular gland, which will obviously cause salivation. So those are the two motor components of the facial nerve, the brachial motor nerve as well as the visceral motor component. And then from a sensory component, the facial nerve receives a little bit of general sensory innervation from the auricle of the ear, but for the most part it doesn't have much of a general sensory component other than innervating this external component of the ear. It does, however, have a visceral sensory component, which is taste that I've already mentioned. So taste from the anterior 2/3 of the tongue will enter through the chorda tympani nerve, run through the facial canal to the internal auditory canal, which will enter the brainstem with a facial nerve, and then will synapse with the solitary nucleus. The solitary nucleus then sends ipsilateral fibers through the central tegmental tract to the ventral posterior medial part of the thalamus, of which then taste is projected to the insular cortex. The same central pathway will be used for the glossopharyngeal nerve, which provides taste to the posterior third of the tongue, and for the vagus nerve, which provides taste of the epiglottis. Looking at the brachial motor component, you can differentiate it clinically. A central facial weakness from a nuclear or peripheral facial weakness can be differentiated based upon the involvement or the lack of thereof of the forehead. I will just briefly remind you that you can distinguish clinically a central facial from a peripheral facial weakness due to either a nuclear lesion, a fascicular lesion, or the peripheral facial nerve. I will just quickly tell you of the underlying pathology. So by looking at these purple lines, we can see that there's bilateral cortical bulbar innervation of this subnucleus of the facial nerve that goes to the forehead, the frontalis muscle, as well as possibly the orbicularis oculi muscle, causing eye closure, whereas there's only contralateral cortical involvement of the subnucleus portion of the face, represented by this green line. And this green line goes to the lower portion of the face, like mouth closure, mouth elevation, as well as possible plus minus eye closure. As a result, if you get a lesion of the cortical bulbar tract, you will have a loss of upper motor neuron innervation to the lower portion of the face, plus minus eye closure. But you will have preserved upper motor neuron innervation of the forehead muscles, which is innervated by the ipsilateral cortex now. In contrast, if you put a lesion at the level of the nucleus, the fascicle, or the nerve, you will have injury to the lower motor neurons to both the upper as well as the lower half of the face, and therefore you will have complete weakness of the whole forehead, eye closure, as well as mouth elevation and closure. You'll have hemifacial weakness on the one side. So still looking at a central facial nerve lesion, we do have other features besides for just forehead sparing. We also get something that's called the mimetic response. So with the mimetic response, what happens is that the emotional component of the seventh cranial nerve is situated in the thalamus, and that's still spared. So if we knock out this cortical bulbar tracts here, what happens is the emotional component of cranial nerve 7 is still spared. Therefore, if you tell a person a joke, it will be overcome. These volitional movements will be overcome by this emotional generator situated here in the thalamus. So let's quickly have a look at an example of this. So this is a patient who's got a left-sided upper motor neuron 7. You can see he's activating his frontalis muscles, and now he's being asked to smile. We can see that there's no movement on the left side of the face. But when he's been told a joke, you can see that the left side is overcome by that joke. And therefore, this emotional response overcomes that volitional response that we get from the cortex. So looking at some of the other clinical features that we find for a peripheral or lower motor facial fallout, I've already mentioned the hemifacial fallout. We also get something, it's what is called as Bell's sign. I will show you now in this video clip what that represents. And then there's also a loss of lacrimation and salivation because of a loss of that visceral motor fibers that I just mentioned. And then there's also a loss of taste through the anterior 2/3 of the tongue because that nerve, the cordon tympani nerve, has lost its special sensory function, and then that creates a phenomenon called the sucking candy sign, which I will show you now a picture about. And then I've already mentioned the hyperacusis because of that loss of that stapedius muscle that we get. And then there's also preauricular sensory fallout because of the general somatic sensory nerve has also been knocked out. And then there's also an entity called aberrant regeneration, which I will show you now. So let's quickly have a look at this video. We can see that this person, the whole right side of the face has been affected. So he's got hemifacial fallout, frontalis muscle, orbicularis oculi, as well as orbicularis oris, some of a little bit of the levitator, as well as the pressor anguli oris, the zygomaticus, and the risorius has been affected when he's being asked to smile. So let's quickly have a look at this. So there he's asked to move his eyebrows. So this is the demonstration of what Bell's sign is about. Okay, so he's asked to close his eyes and look at this white sclera sticking out of, is showing, and that means that's typically what we refer to as a Bell's sign. The sclera sticking out when you're asked to close the eyes, activating that orbicularis oculi muscles, and therefore there's incomplete activation, causing the sclera to stick out. And as we can see, there's almost no movement around the mouth, and there's no activation of those muscles that I've just mentioned. And even an emotional response does not overcome this, as we can see now. There's an automatic emotional response when he laughs. Remember, so this was preserved in upper motor neuron 7 because that thalamus was still preserved when we had an upper motor neuron lesion or central facial nerve. So let's look at the other clinical features that we get. So this is, remember, some of the one of the features that I mentioned was the sucking candy sign. So if you give a person a lollipop, they will obviously choose the side where they can still taste the sweet sensation, and therefore they will stick it to that side of the mouth, and it will start to discolor the tongue on that side. So that would be the normal side. And then I've mentioned aberrant regeneration. So the way to describe aberrant regeneration is something like when you want to go to, so let's imagine that you want to go on holiday. So you want to drive all the way down to Cape Town, but now a lesion happened on this highway. So that would be the 7th nerve. So there's some roadworks happening now. So now you have to take a detour. So you're going to go via Durban to Cape Town. That's obviously a massively long detour that you're going to take now. So this is something similar that's going to happen here. So instead of your facial nerve that's going to innervate your orbicularis oris muscle, it's going to also innervate the orbicularis oculi. So when you close your eyes, you're going to smile. There's also something that's being referred to as crocodile tears. So with what happens in crocodile tears, the nerve that was supposed to go to the lacrimal glands are now also going to the salivatory glands. So the moment you start smelling that good food in the kitchen, you don't just start salivating, but you also start tearing. And then also something similar can happen with the gustatory sweating phenomenon. That's when you start smelling good food, it just doesn't go, it goes all the way to a completely different organ and it innervates the the sebaceous glands in the face, and therefore you start sweating on that side of the face. So let me quickly just take you through this recording again of this video clip just to demonstrate this aberrant regeneration syndromes. So we're going to ask the person to close his eyes, and while he's closing his eyes, I want you to pay special attention to the lower half of the face. And you will see this movement around the lower half of the face when he's being asked to close the eyes. So it seems that it's a benign condition, but sometimes it can be mistaken for as being focal aware seizures. So this is something to take note of. So let's look at some of the other pontine syndromes that we get. So these are typically associated with when we see small lacunar infarcts in the brainstem. So let's start off with ventral medial pons. So if you remember by the localization principles, we mentioned you first have to localize on a vertical plane and then on a horizontal plane. Then we're going to go to dorsal, and then we're going to go to ventral. So now this lesion, Raymond syndrome, is a lesion situated in the ventral pons. So what do we have that sits ventrally? We have the pyramidal tracts. Remember, motor on the ventral side. So this person is going to have weakness on the contralateral side of the body. In other words, affecting the right arm and the right leg. So that's on the ventral surface. So let's look where else is this lesion? Is it situated now laterally or medially? So obviously, if you think about the 4 S's and the 4 M's, we know that this is going to involve the 4 M's. So which other M's do we see when we think of medially? We think of, besides for the general motor, we have the motor of cranial nerve nuclei that's being affected. So which cranial nerve nucleus do we typically see here? That's going to be affected in this syndrome, in Raymond syndrome. Very medially, we're going to affect the abducens nerve because it exits very medioventrally at the pontomedullary junction. And then the second type of pattern that we see would be the ventral medial as well as a little bit of the lateral pons. And that's going to affect the same combination of nerves that we saw with Raymond syndrome, the corticospinal tracts, as well as the abducens nerve. But you're also going to see facial nerve involvement. Because the facial, remember I said it's situated a little bit more ventrally, and then it wraps around that 6th nerve, so the 6th nerve nuclear complex before it exits. So therefore, in something called Miller-Gabler syndrome, you're going to find that the 7th nerve, the 6th nerve, as well as the corticospinal tract involvement, causing weakness on the opposite side of the body, but these two will have ipsilateral fallout patterns in the face. Okay, well now I'm going to move to the vestibulocochlear nerve, the 8th cranial nerve. This should really be considered as 2 separate nerves, the cochlear division as well as the vestibular division. And that's how I will approach these. We'll begin with the cochlear division. So the vestibulocochlear nerve is a special sensory nerve. It's the only special sensory nerve in the brainstem. So when we talk about hearing, it transduces hair cell movement into the cochlea into neuronal signals that will then be transmitted to the brain and be interpreted as sound. So the 8th cochlear division of the 8th cranial nerve has its cell bodies that lie inside the spinal ganglion. What will then happen is that these axons will come into and synapse to the cochlear nuclei that were now situated in the caudal pons by the 4-4-4 rule. So those 2 cochlear nuclei are the dorsal and ventral cochlear nuclei. And from there, some axons will decussate and some will stay ipsilaterally to synapse with the superior olive, also known as the trapezoid body complex. At this point of redundancy is very important because clinically this is the reason why lesions in the rostral pons as well as the midbrain and the thalamus, or in the primary auditory cortex, do not cause hearing loss because there's redundancy of information going up on both sides of the brainstem. The only neurological areas in which hearing loss do occur are when there's injury that occurs of the cochlear portion of the vestibular cochlear nerve itself, or in combination of the dorsal and ventral cochlear nuclei inside the brainstem. So from this superior olive, what then happens is that axons will run up in the lateral lemniscus to synapse at the inferior colliculus. So there they will send axons to the medial geniculate bodies, which will then synapse, and then they will send axons to the primary auditory cortex, known as Hirschfield's gyrus. So this has clinical implications in this test right here, which is the brainstem auditory evoked response. There are 7 waves in this brainstem auditory evoked response, and these are roughly corresponding to the different regions of the hearing transmission system that I just discussed. So the first wave that you see after giving repetitive auditory stimuli is here, and this is wave 1. Wave 1 refers to the kind of peripheral portion of the cochlear division of the vestibulocochlear nerve. Next, you see wave 2. So wave 2 refers to the more proximal portion of the cochlear nerve, as it is entering the pons or the dorsal and ventral cochlear nuclei. The third wave refers to the response at the superior olive. The fourth wave is the axons as they run into the lateral lemniscus, and the fourth and fifth wave often form a complex, as shown here. The fifth wave is at the level of the inferior colliculus. The sixth wave is in the medial geniculate nucleus of the thalamus, and then the seventh wave represents the primary auditory cortex and the temporal lobe, or otherwise known as Hirschfield's gyrus. Okay, so looking at the anatomy of the 8th cranial nerve's vestibular function, we can see it's quite a complicated system. There's lots of axons running in many directions, but I'm going to highlight the key clinical pieces, and so I'll try to take everyone through a simplified approach. The first thing is we're going to divide the information that comes through the vestibular portion of the vestibulocochlear nerve into 2 subtypes. There's the subtype that detects rotational movement, and there's the subtype that detects linear movement. So rotational movement of the head is detected by 3 pairs of semicircular canals, the horizontal canal and the anterior and posterior canal. In contrast, linear motion of movement is detected by a paired saccule and utricle. I'll start with rotational movement and briefly look at linear movement. So when you're detecting head motion, what actually happens in the level of the vestibular apparatus in any of these one of three canals, there is tonic neuronal firing, which are coming in from both ears simultaneously, originating from all 3 canals, and those firing rates should be exactly equal. This is the tonic firing rate. So when they are equal in your brain is determining that these equal signals means that your head is not moving. So when your head is actually turns, fluid moves, and that will bend the cilia, including the large one that is called the kinesiolium, on the hair cells inside of any of those canals. When the cilia bends towards the large kinesiolium, that tells the nerve to fire faster. And when the cilia bends away from the kinesiolium, it will tell the nerve to fire slower. And therefore, you have an ability when you move your head rotationally from right to left or vice versa, you get an increased firing or a decrease in firing pattern. So let's put that together with a pair of canals. So the right and the left horizontal canals pair together. So basically they have a push-pull mechanism. So when you turn the one side on, you will turn the opposite side off. And when you turn the opposite side on, you'll turn the original off. So here's an example. The patient is asked to turn his head to the left. What will happen is that fluid will flow, bend the cilia towards the cilium, which then will activate the left horizontal semicircular canal. The exact same movement will move the fluid in the opposite direction on the right, causing a decreased firing in the right horizontal canal, as seen here. And this amplifies the difference between baseline, when they are both firing at the same rate, and tells your brain that your head is rotated to the left. What it does with this information, I'll go through in a second. This information will run through the vestibular portion of the vestibulocochlear nerve and will then synapse in any of the 4 vestibular nuclei. There is the superior and inferior, medial and lateral nucleus. The rotational movement usually synapses at the superior and at the level of the superior and medial vestibular nucleus. So that was quite easy to imagine these push-pull pairs of horizontal canals. Now there are similar push-pull pairs between the anterior as well as the posterior canals as well. But we have to understand that these pairs are not anterior and anterior, but actually the opposite. The right anterior pairs with the left posterior. The left anterior pairs with the right posterior. The anterior canals is stimulated when you move your head anteriorly, and the posterior canals are stimulated when you move your head posteriorly. So if you move your head to the right anterior, that will stimulate the right anterior canal and inhibit the left posterior canal. If you move your head left and posteriorly, that will activate the left posterior canal and inhibit the right anterior canal. So what happens when you activate or inhibit these canals? They will all go to the certain extraocular muscles which allow for the oculocephalic reflex to occur. So when your head moves in one direction, the oculocephalic reflex moves your eyes in the opposite direction. So if I move my head to the left, I need to move my eyes to the right. Then when we look at the horizontal canal, it will innervate the muscles that will move the eyes into the opposite direction. So if I turn my head to the left, I will activate my left horizontal canal, which will then activate my right lateral rectus to move into the right, as well as my left eye's medial rectus to move to the right as well. Remember, this is termed as the doll's eyes reflex. So the posterior and anterior canals move the eyes in a vertical direction. So the posterior canal is activated when you move your head posteriorly. In other words, the eyes will need to come down, so you will need to activate the depressors of the eye, which is the superior oblique and the inferior rectus. And when you move your head anteriorly, you will need to elevate, so that is going to reach out to the muscles that elevate the elevation of the eye, namely the superior rectus and the inferior oblique muscle. So the pathway for this is from the horizontal canal. We will then go into the vestibular nuclei that relays second order neurons to synapse with the contralateral sixth nerve complex, which will then recross over via the MLF to the ipsilateral medial rectus oculomotor complex. This simple pattern here is for those vestibular nuclei which send out axons that will always cross into the MLF and synapse to the contralateral sixth nerve, as well as again the ipsilateral third nerve nuclear complex. Okay, so now I'm going to put this into clinical context. So here I have a patient who is coming in with a sustained vertigo, nausea and vomiting following a viral illness. The hearing is normal. So the first what we're going to do is to do the head thrust or oculocephalic reflex. Here the head is turned to the left, and this is where we can see a catch-up saccade. And here the patient's head is turned to the right, and the eye moves into the opposite direction. Right again normal, left catch-up saccade. So when you see that phenomenon, it is an abnormal oculocephalic reflex. In other words, the eyes are not reflexively moving in the opposite direction of the head. They are moving with the head. This will localize to a deficit in either the left horizontal canal or in the left vestibular portion of the vestibulocochlear nerve. Additionally, this could be the same patient. It's different, but with the same story as we can see in the history above. So in addition to the abnormal ocular cephalic reflex, you can also see nystagmus with dysfunction of the whole vestibular nerve. I will now show you what this nystagmus looks like, and then I'll try to explain to you why it looks like this. So here the patient is asked to look straight ahead, and what we can see here is that the eyes are drifting to the right and beating to the left. When he looks to the right, the nystagmus virtually goes away, and when he looks to the left, it gets much more impressive. And this is called Alexander's law, and that's typical of a peripheral process. So in other words, something affecting the vestibular portion of the vestibulocochlear nerve. So the nystagmus gets worse looking to one direction, typically away from the affected ear, but it gets better when it looks towards the affected ear. So the classic nystagmus with the dysfunction of the vestibular portion of the vestibulocochlear nerve is a mixed horizontal and torsional nystagmus, away from the affected nerve. In addition, you will see an abnormal oculocephalic reflex or head thrust in the direction of the affected ear. So what is the story behind this nystagmus, or why is nystagmus like that? Well, you'll get a beating phase due to the horizontal canal dysfunction, and you'll get a torsional phase due to the anterior and posterior canal that are involved. So basically, let's say you have a right vestibular neuritis. What will happen is that there will be no signal coming in tonically from the right vestibular portion of the vestibulocochlear nerve, including the horizontal canal. The left side will still fire at its normal tonic rate. As a result, your brain will feel like your head is moving to the left, though your head is actually not moving at all. Therefore, your eyes will have an oculocephalic reflex as if your head was moving to the left. That means the eyes will drift to the right, and they will then be corrected back because your head is not actually moving at all. So in this case, the dysfunction of the horizontal canal on the right will cause a drift to the right and a fast beating to the left. Another clinical manifestation in understanding the underlying vestibular system is with benign paroxysmal positional vertigo. So as you know, BPPV is caused by the disruption of these canals by a crystal or an otolith. The crystal will then enter the gravity-dependent semicircular canals, usually the posterior canal. This is an activating process, and as your head is moving, the fluid is moving, and the crystal moves as well. And as your head stops to move, the fluid will stop moving, but the crystal will still move on to find the gravitational null point. So to your brain, it feels like your head is still moving. So let's see what it looks like, and then I'll try to explain the nystagmus that we're seeing. So this patient is going to be placed right backwards. The ear that is going to go down is going to tell you the affected posterior canal in BPPV. So we are looking for a right posterior canal, BPPV in this case. So what we can see here is when we are looking at her right eyes, an upbeating nystagmus is present, and there's a rotational component to the right side, and that is best seen by looking at the blood vessels in the conjunctiva. It also slows down as the crystal finds the null point in gravity. Okay, so now I'm going to switch from rotational movement to linear movement, which is a little bit more complicated. I'm going to talk about one linear movement due to the others falling beyond the scope of this presentation. So I'm only going to talk to you about head tilt, unlike rotational movement that is detected by those three semicircular canals. So linear movement is detected by the utricle and saccule. Head tilt is primarily detected by the medial utricle. So the medial utricle will project its fibers through the vestibular portion of the vestibulocochlear nerve. It will then synapse at the vestibular nuclei. It will then send fibers decussating into the MLF, where it will synapse at the contralateral trochlear and oculomotor nucleus. So when you tilt your head, you need to raise up the eye that it's on the same side as the head tilt and rotate it inwards. You will also need to depress the contralateral eye and rotate it outwards. So that is for a normal connection, this counter-rolling phenomenon. Okay, so looking at this pathway again, the way it does this is by going from the oculomotor nucleus, which then sends across back to the superior rectus. So when you ipsilaterally head tilt the eye, on that side it's elevating through the superior rectus muscle and intorting through the superior oblique muscle via the fourth nerve, while the contralateral eye is depressed via the inferior rectus and extorted via the inferior oblique by the third cranial nerve. So I know this is a very difficult concept to grasp, and this is only for extra information. You do not have to know anything that I mentioned on this slide. It's just for interesting sake that I'm telling you about this. So let's look at what will happen if you have a lesion that disrupts this utricle information centrally. You'll get something that is called a skew deviation, which is a vertical misalignment of the eyes not caused by a third or fourth nerve palsy. So this is a skew deviation associated with a patient with a posterior circulation stroke. The cover-uncover test is being performed. So here we can see that the right eye is going up and the left eye is coming down, which is best seen by looking at the patient's eyelid. Therefore, he has a left-sided hypertropia. Okay, so let me explain the clinical localization of a skew deviation. There are tonic firing rates from the utricle coming in from both sides. If I have a lesion on the right vestibular portion of the vestibulocochlear nerve as it enters the pons, then what will happen is that there will be persistent firing to the left side with absence of the right-sided functioning. And it will feel to the patient as if their head is tilted to the left, even though their head is still straight. As a result, their eyes will move as if their head is tilted to the left. So that means the left eye is going to elevate and intort, and the right eye is going to depress and extort. This is called the low-low lesion. That means the depressed extorted eye is ipsilateral to a lesion of the right dysfunctional vestibular portion of the vestibulocochlear cranial nerve. If instead you injure those axons in the MLF at the level of the midbrain, the fibers have actually crossed already, but it's still injuring those utricle fibers as they are running up in the MLF. It is therefore important to remember that there is still the same fibers coming in from the right vestibular portion of the vestibulocochlear nerve, and it will still feel like the patient is tilting their head to the left, but in this setting it will be towards the lesion, which is located on the right. So it will feel like an ipsilateral head tilt. So in this case of a midbrain lesion, the high eye is on the side of the MLF deficit, indicating a high lesion. So this principle that I'm describing now is very complicated to understand, and you will not be tested upon it. Alright, so I'll finish up with cranial nerves by going through cranial nerve 9, 10, 11, and 12 much quicker. So the glossopharyngeal nerve is a kind of a dinky nerve, but it does have multiple different columns that it contributes to. It has a brachial motor column that only goes to one muscle, the stylopharyngeal muscle. And as a result, it is a pharyngeal constrictor, and the clinical deficit in that muscle is virtually undetectable. The nucleus that provides the constriction to that muscle comes from the nucleus ambiguus. The nucleus ambiguus, as I mentioned earlier, is named that because it actually provides brachial motor axons to 3 cranial nerves 9, 10, 11, and 12. So we'll come back to that nucleus when I talk about those cranial nerves. So the glossopharyngeal nerve also has a visceral motor component. The visceral motor component is going to end up in the parotid gland due to salivation. It arises from the inferior salivatory nucleus and will run in the glossopharyngeal nerve until it enters, breaks off, and divides into the lesser petrosal nerve, which will then go to the optic ganglion and eventually to the parotid gland. As I mentioned earlier, cranial nerve 9, the glossopharyngeal nerve, has a visceral sensory information that comes from the posterior third of the tongue to do taste sensation. It will therefore end up in the rostral solitary nucleus, and then we'll have axons that ascend into the central tegmental tract, just like the cordon tympani did, which I described with when I looked at the facial nerve. These tracts will eventually end up in the insular cortex to mediate taste sensation. This nerve also has visceral afferent fibers, which is the first time we're talking about in this column. It also goes now to the inferior solitary nucleus, and the key component here is that the anterior limb of the gag reflex, or the afferent limb of the gag reflex. It also provides visceral sensory information in the oral cavity and a little bit in the throat as well. Right, so the vagus nerve. The vagus nerve, again, is a nerve composed of multiple nuclear columns. It also has a brachial motor component, which is going to do the muscles of the soft and hard palate. It's going to go to the pharyngeal constrictors, and it's going to have axons that run initially in the 11th nerve before joining the 10th nerve, which will eventually make up the innervation of the larynx for speaking. This is all coming from the nucleus ambiguus, and as I mentioned earlier, a lesion of that nucleus, as can be seen in lateral medullary syndrome, will cause dysphagia and dysarthria through that mechanism. The vagus we think about is primarily a visceral motor component. It does the visceral motor innervation of the heart, the lungs, the blood vessels, the GI tract, all the way to the first 2/3 of the colon. And all of the innervation comes from the dorsal motor nucleus of this vagus nerve. It also has visceral afferent information from all of those organs, which will go to the inferior solitary nucleus. And it even has some taste innervation from the epiglottis, which will go to the rostral solitary nucleus. So if you have a nucleus ambiguous lesion, besides for the patient having a dysarthria and dysphagia, one of the things that you will often see is uvular deviation, and the uvula deviates due to weakness of that muscle right here, the levator villi palatini muscle. And so what happens if you have an ipsilateral vagus nerve lesion, this muscle won't contract, and when you ask the patient to say ah, this normal levator villi palatini will not work. And as a result, it will cause uvula to deviate towards the normal side, away from the affected side. So what does this look like clinically? It looks exactly like this, where the patient is asked to say ah, is able to elevate over here, but is not able to elevate over on this side, and the uvula deviates. The affected side is the vagus nerve on the left side. So you can see that this muscle, the levator villi palatini, is still contracting on this side, causing the uvula to deviate towards the normal side, away from the affected side. The vagus nerve nucleus ambiguus has kind of bilateral cortical bulbar innervation, so it's unusual for it to be affected from an isolated upper motor neuron process, and instead a peripheral nerve or neuromuscular junction process is much more likely to affect this nucleus, causing a dysphagia or dysarthria. The accessory spinal nerve, the cranial portion of the accessory spinal nerve, is derived from the nucleus ambiguus as well, and it's somewhat anatomically controversial as to whether or not it's really a separate portion of the vagus nerve or just a branch of the vagus. The key portions that we think about of clinically with the accessory spinal nerve are the spinal portion of the accessory spinal nerve. Those derive from C1 to C5 anterior horn cells or intermediate horn cells. And so the axons actually exit from C1 to C5, and then they ascend through the foramen magnum with a spinal accessory nerve before they turn around and leave with the spinal accessory nerve, the vagus nerve, and the glossopharyngeal nerve as they run through the jugular foramen. The spinal accessory nerve with the spinal portion only receives unilateral cortical bulbar innervation, and this explains the direction in which a head turns during a seizure. So what does the accessory spinal nerve do? It goes to the two primary muscles. It goes to the sternocleidomastoid muscle that connects the mastoid to the clavicle and the sternum here on the more distal side, as well as the trapezius muscle that extends over on this side. When the sternocleidomastoid muscle constricts, it causes the head to turn, but it causes the head to turn away from the muscle that is constricting. As a result, a unilateral spinal accessory nerve lesion will cause ipsilateral difficulty abduction of the shoulder above 90 degrees, which is the trapezius's function, and it will have a deficit in contralateral head turn due to the normal sternocleidomastoid muscle that's still able to contract. And finally, we get to the hypoglossal nerve. So the hypoglossal nerve, along with the glossopharyngeal, the vagus, and the cranial portion of the spinal accessory nerve, are all in the medulla by the 4-4-4 rule. So the hypoglossal nerve is a pure motor nerve. It innervates the intrinsic muscles of the tongue, as well as all of the extrinsic tongue muscles, except for the palatal glossus, which is innervated by the vagus nerve. So it allows you to move your tongue, protrude it, as well as moving it left to right. The way you protrude your tongue is through the muscles down here, which is called the genioglossus. This attaches to the posterior surface of the lower mandible, and it also attaches to the actual tongue itself here in the back. So this muscle constricts and pulls the tongue forward by pulling the back forward. This explains in which direction the tongue will deviate. So if you have an ipsilateral hypoglossal nerve lesion, you would expect atrophy of the intrinsic tongue muscles on the side of the lesion, and then you would also expect tongue deviation to the genioglossus dysfunction. So if this genioglossus on this side doesn't work, but on that side it does work, it will pull the back of the tongue towards that side, which will then move the front of the tongue towards the side of the lesion. So the tongue deviation is towards the side of the atrophy and towards the side of the hypoglossal dysfunction. And here's a patient with tongue deviation to the left, decreased muscle bulk of the tongue on the left compared to the right. So this is consistent with the left 12th nerve palsy at the nucleus, the fascicle, or even at the peripheral nerve itself. You can see the tongue atrophy with the grooves and folds on the left side of the tongue, and then the tongue deviates to the side of the weakness. Okay, so finally we're going to look at one of those brainstem stroke syndromes again, and this is where I'm going to apply again the rule of 4-4-4s. So if you remember, if we think about first localizing on the vertical plane, and we think of the medulla, we're going to think that these patients are going to develop a dysphagia as well as tongue deficits when you've got somebody that's got a lesion in the medulla. So now we're going to localize on a horizontal plane. So the first thing would be to start dorsally and then to go ventrally. So if we go ventrally, a patient with a medial medullary syndrome will have corticospinal tract dysfunction. Remember, that's the motor ventral. Dorsal was cerebellar, sensory, and trochlear nerve dysfunction. But we don't have that here. This is medial ventral medullary syndrome. So the motor movement will be knocked out, causing a contralateral hemiplegia or hemiparesis. So the second step in the medial medullary syndrome would be to go look medially. So think laterally and then think medially. So this is a medial syndrome. So then we get the 4 M's here. So we've got the M, the first M, which is motor. We've already discussed this. And then the second M would be the motor for cranial nerve nuclei. In other words, the hypoglossal nerve. And therefore, we get ipsilateral tongue deficits on the same side of the hypoglossal dysfunction, but contralateral deficits in the long tracts. And therefore, we've basically summarized medial medullary syndrome by just applying the rule of 4s. And that concludes our discussion of the brainstem and cranial nerves. I hope you learned a lot today and enjoyed this discussion. I look forward to discussing further topics with you in clinical neuroanatomy.